What made you specialise in addictions?
The reason I specialise in addictions is because I just loved it. We do medical training, you spend a few months doing every specialty, and I typically was excited to begin with and then was bored by the end of it. But it was the only area that I was more excited at the end of doing that placement, and so I've stuck with it, and I'm still excited by it.
Wonderful. And so how does that, is that unusual in psychiatry, do you think, speaking to your peers?
Yes, I think a lot of people, and I would say the majority of peers or colleagues, tend to think, oh gosh, addictions, that's hopeless, couldn't work with that patient group. There's a sort of sense of despair about it, or tricky patients to work with. But I find it completely the opposite, because actually that patient group are some of the most authentic and real, and I learn. I'm just constantly learning from that for myself personally. But it's just such an exciting field, and things are so changing all the time, including what goes on around the world. In Afghanistan, etc. It affects drug lines, so it's an ever-changing field. It's not static.
And I guess maybe it's perceived as a field where there isn't much certainty in terms of the evidence base, because it's so under-researched, it's so underfunded, both in terms of the science as well as the services. Does that add to that kind of sense of we can't really help because we don't know what to do?
It might do for some. I think there's some really good evidence base to guide practice, and when you compare with actually other areas of medicine, and including psychiatry, there's some really strong evidence in addictions. It's not an easy area to work in terms of you do something and you get a quick result, because you're often dealing with a long history of trauma that's behind many of the addictive behaviours. But it's incredibly rewarding, and I think for me what motivates me is advocating for equitable treatment, just as human beings, with all other people in society, and not to counter that discrimination. And you get that from there's physical health with mental health parity of esteem, but there's an equal gap between mental health and people with substance use problems, and there's a gap there of care, and so it's advocating for that, just equitable care, really.
Yeah, and I suppose over the last 15 years or so, with all the anti-stigma work, we've seen a lot of people within the mental health area who have benefited from that in terms of the way society views them, but people with severe mental illness, people with addiction problems, people involved in violence in some way, I suppose those are still quite groups that are viewed as in some way bringing this on themselves.
Yes, it's the judgment that comes, and it's trying to counter that judgment and actually say, if you walked a mile in that individual's shoes, would we be anywhere, any different? So it's trying to bring compassionate care, but obviously that needs to be delivered as well in a structured, boundaried way, and it's that balance that I think is needed.